In today's episode of Q&A, we talk about many topics throughout all realms of health and fitness, not just hormones, not just hair loss. We talk about things like exercise, very personal questions as well. But we thought that this was one example of an interesting question.
Hey guys, wondering your thoughts on DHT in relation to combining creatine and finasteride. Will this cause less effectiveness of either one? Stay tuned for that answer and more. And then we have Juicebox86 with the talk about getting sun exposure for circadian rhythm sync per Papa Huberman. Does he call himself that?
Papa Huberman. I doubt it, but there's probably a lot of people who do.
And fringe folks like Jack Cruz demonizing the blue light in modern fixtures, touting benefits of red dominant sunlight. Basically, the question is, how much sun exposure is too much? Where does cancer risk start to take off?
Yeah, depends on the individual. For those at high risk of skin cancer, they have a strong family history. I believe at least one of the medical societies, perhaps it's the American Academy of Dermatology, says no more than 15 minutes of unprotected sun exposure per day.
Yeah, and I think that's the key, is unprotected skin exposure.
Yep.
So if you're getting sunburned, that's too much. If you are not getting sunburned, then, probably take two people that don't ever get sunburned, but one of them's outside 12 hours a day, the other one's out 0. You're still going to get a little bit of that UV damage, a little bit of mutations and DNA damage that's going to make you more likely to get skin cancer later on. But unless you're on the extreme end of that spectrum, and the extreme end being high risk genetically, then I think it is more about avoiding burn versus putting a timer on.
Yeah. And also, to be clear about the circadian benefits of sun exposure, that comes from the different wavelengths of light, especially the blue wavelength, going through your eye, goes to your retina, your optic nerve, and turns off your pineal gland. That's a circadian rhythm benefit. So you don't need to, you're actually not going to get as much of that benefit if you just go outside and bake with, like a sun mask over your eyes. You're going to get a good benefit if you walk outside in the morning when the sun is actually very weak on your skin, lower cancer risk, and you're still taking in that light through your eyes, but not directly. So you don't have to look at the sun to get this benefit.
Yeah, and I think that Papa Huberman, as he's referred to here, specifically tells people not to stare at the sun.
Yes.
That's a pro tip. Actually, my dog needs to learn this, because I'll often see her out in the yard and she's just staring at the sun. Not the smartest, but she hasn't listened to enough Huberman podcasts yet.
Yeah, poor Zoe. At least she's cute.
Yeah.
What are the things that helped most of your patients with PFS? Was it HCG? Is it TRT? ?
That's an interesting one. I think one of the things that has helped them the most is just someone finally telling them, hey, there's things that we can evaluate, check off a list, things that we can try, as opposed to saying, hey, this is all in your head.
Yep.
This is not a real condition. People sort of gaslighting them. So I would say that's sort of something I would put up there. Yep. I don't know if that is more or less helpful in the long run than someone who's had a successful recovery after a couple of courses of HCG.
Yep.
But that's, I think, an aspect that I think is overlooked, because a lot of these times these people don't know exactly where to turn, who to talk to, in order to start exploring, is there something else causing this? Is it actually from an androgen deprivation sort of syndrome?
It reminds me of patients who have had side effects on statins in the past, regardless of if it's myalgias or something else. And thinking about the question, what has helped most of your patients that have had statin side effects in the past? And it's really the same thing.
Repatha?
But in all seriousness, it's, having someone listen to you. They talk about your lifestyle. They talk about everything else that could be potentially affecting, worsening that. And they find a unique plan to improve it.
Yeah, I think that's all jokes aside, I think that is a good summary. This says, do Dr. Gillett and James O'Hara take Dutasteride? And someone said, do you take it or not, though? So I guess our short wasn't clear.
We said yes. Or we said yes, but I just don't remember. Yes. Yes, we have in the past or are currently taking it. That's the question.
Have in the past and or currently do and or will in the future.
Let me put it this way. As long as I'm not actively trying to make normal epigenetic sperm or just normal sperm in general, I will be taking dutasteride. So if I'm not taking dutasteride, it's because of my sperm, not because of literally every other organ system in my body.
Good answer. I think we may have just confused them a little bit more with that one. So
Yeah.
that'll be fun.
Next is, if I take dutasteride, will it affect the development of my facial hair? I don't think it has in my case. I think I've actually developed more facial hair since I've been on dutasteride off and on. Is there less DHT in the body? If there is less DHT in the body, less hairs on my face will become terminal hairs. It is a great question because if this individual is 15 years old, I would say absolutely.
Yeah. It depends on the time and point in life someone is at. I've sort of had the same experience. I don't think that there's been any decrease. If anything, probably a slight increase in the rate or volume of facial hair growth. Mm-hmm. So if this person is, let's say, above the ages of 25 and they have, let's say, a normal full panel, their testosterone doesn't need to be 1,000 nanogram per deciliter, but it's not at 100 nanogram per deciliter.
Yeah.
Then or perhaps this person is a woman asking if the dutasteride would affect the development of facial hair.
That's a good thought. I should have thought of that. In that case, it also depends on total androgen pool, what your previous disposition has been, and if you have been in a higher androgen state in the past.
Yeah, I would say for a woman who is going on a testosterone therapy of any form, that the dutasteride would make the vellus hairs much less likely to turn terminal, but it probably is not going to reverse hairs that are already terminal. Which, probably, even if you put women on a placebo, you're going to see anywhere from 5 to 15% of them, claim that they got androgenic side effects because they start noticing those things.
I believe there has literally been a study on testosterone in women where they took placebo and 15% developed excess hair growth, hirsutism.
Yep, and that's just from their own exposure to DHEA, testosterone, and DHT over a lifetime.
Next is related. Does DHEA convert to estradiol in menopausal women? Yes. I believe Dr. Fernand Labrie is the one that showed after the ovaries stop working, adrenally produced DHEA is the sole source of estradiol. He coined the term intrachronology. A lot of times this happens intracellularly, just like DHEA can enter a sebaceous cell and very quickly convert to DHT in a series of a couple different reactions, a huge portion of it. So yes, you see estradiol frequently go up, but especially in females, you also see intracellular DHT go up. So I guess we've come full circle and DHEA is now a very strong androgen in the skin.
Well, in the DHEA is not going to give you the same profile as something like a adequately dosed estradiol patch would. You're not going to see a stable level in the serum and that sort of reflecting what's going on in the tissue. It's a little bit more variable.
Next is there something wrong with taking 2.5 to 5 mg Cialis, which is tadalafil, 3 times a week if you're getting ED from finasteride or dutasteride? If the individual does not have low enough net androgens, it's very interesting. Total and free T are very high, but I lose about 10% of erectile quality. The microdose of Cialis seems smarter than going bald, given that I can get 2 years worth of it cheap from Cost Plus. That's true. Another Cost Plus drug, shout out for generic meds.
And they say this is a long-term thing, like 10 to 15 years. So this person sounds like a regular listener of the podcast because we were like, they're going to say, see if you have low net androgen. So I'm going to put that in the question.
Yes.
And they say,
I love it.
Well, I don't want to go bald. So I'm going to put that in the question as well.
Yep.
And then also I want to define my time frame. So they've got us in a corner here. What are we going to do?
Here's the other questions. So if you also happen to be trying to start a cookie cutter hair loss telemedicine startup, then you can include this in your intake questionnaire algorithm. So here's some free, not medical advice. Androgen to estrogen ratio. So I guess you could, this guy is pretty sharp. Total net androgens and total net estrogens, are those equal? Perhaps if estradiol and free estradiol are running high, then that could be the mechanism. Progestogen pool, so pregnenolone and progesterone, and then from that you can kind of get a rough estimate of how much allopregnanolone and isoallopregnanolone are looking. So what are those things looking like? And then prolactin. If your estradiol is also high, is that secondarily increasing gene transcription at the PRL gene, driving prolactin up? So take a look at that as well. Any of those things, and again, the prolactin and dopamine tug of war, that can certainly affect things.
I would say, I guess, two other things to add to that would be looking at, lipids and risk for heart disease, atherosclerosis, and then also your metabolic health. So it's looking for insulin resistance, because those two things can contribute to erectile dysfunction, and perhaps one or a combination of those two things plus a drop in DHT is sort of unmasking this, right?
Yeah. Not uncommon, especially as age increases.
Then you can cover it up with the Cialis, but the question is more about, making sure that there's not something going wrong there from a cardiovascular disease standpoint.
Yeah. If this is a 10 to 15 year thing, especially if this individual is, in 40s or even 50s or 60s, then lipids are probably the first thing to look at, because anytime, and they teach you this in med school, canary in the coal mine. So the canary dies of carbon monoxide poisoning first in the coal mine, so the coal miners don't have to. And it's the same thing with ED. Erectile function dies before coronary function does. I guess it seems fairly reasonable to design it that way, or naturally select that way, whatever the case may be. But yeah, even things like high lipoprotein (a) is a significant risk factor for slightly later in life erectile dysfunction.
Yeah, good points. Next we have, this was a comment on our Tonkat Ali and Fadogia agrestis podcast. Someone says, curious, Huberman mentioned that Fadogia causes testicular size increase, and you all mentioned that it decreases, which would be true. I don't think that we said specifically it decreases testicular size. Yeah,
in the animal studies, I believe this is what Huberman is referring to, show that Fadogia agrestis can increase the size of the testes. But if you're looking at the LH sensitization effect, so it doesn't decrease the size of the testes that we know of, but there's really no human studies, so you don't know that well. But like a lot of herbal medicines that have been taken for hundreds of years and are considered well tolerated, this is another supplement in that category, kind of like as far from pharmaceutical medications as you can find. But one of the things that's unique about it is it does appear to get you more bang for the buck at the LH receptor. So it can likely resensitize that LH receptor to LH, which you can use in individuals with previously actually high LH, but it often increases LH even more and sensitizes the testes. So with the same amount of LH, you likely don't need, it helps with the efficiency of the testicle. So that's likely what the commenter is referring to.
Yeah, I think that makes sense. And then we have another interesting theme here. According to Dr. Andrew Huberman and other doctors like Dr. Berg, 1,000 milligrams of omega-3 and 2,000 milligrams of inositol are effective for depression or anxiety. They both assist the body with brain inflammation, neuroinflammation, making its own nutrients, regulating insulin and hormones with little to no side effects for most people. Why are doctors prescribing ketamine when it very obviously ended the life of actor Matthew Perry? It's like his doctors never allowed him not to be an addict by prescribing him addictive substances. Very sad. I think we can avoid the last part of that and say, why are doctors not recommending omegas and inositol more and recommending other prescriptions?
Yeah, so the way to think about this is if there is an insufficient or deficient level of omegas or inositol, it makes a huge difference. It's just so common in this country's or any developed country's population that they don't have that they have insufficient omegas or that they have insufficient inositol levels, that they happen to make a difference. Same reason why zinc and magnesium and selenium and vitamin D can make a difference for testosterone. If you check the average person's vitamin D, it's not optimal. So it can improve it, but people who are already healthy and who already have sufficient levels of these things, it's not going to be significantly helpful for mood disorders. The alternative to that, or the opportunity cost, most people who are seeing psychiatrists or even family medicine doctors, by the time that they're seeing this, these conditions have progressed to where they're no longer mild, which is where these supplements would come in. They're very severe conditions. Perhaps there's suicidal ideation, perhaps there's mania, it could be bipolar depression. It's hard to say, but for more severe pathologies, that's when stronger therapies are going to be indicated.
Yeah, and I think that makes sense. And also taking into account like an individual's, finances, talking about the family medicine picture and the traditional healthcare environment, like a substantial dose of omega-3s with enough of the EPA in there to blunt the neuroinflammation is going to be substantially more than, an SSRI that's on, Walmart's $4 list as an example.
Yeah.
So everyone has a different situation. And I think that these doctors are trying to do the largest amount of good in the shortest amount of time. And that's sort of where they end up.
Yeah, that's a good summary. A couple other notes. I don't think inositol is technically a B vitamin, but a lot of people call it vitamin B8. And as far as we know, lithium, likely whether it's lithium caproate or lithium orotate, which is organic lithium, does seem to deplete inositol levels, especially in the CNS. So we do really like inositol as a supplement for many reasons. Sleep and mood is just one of them. Next, hey guys, wondering your thoughts on DHT in relation to combining creatine and finasteride. Will this cause less effectiveness of either one?
I actually have a couple of data points on this in individuals. There was a 1 nanogram per deciliter difference from when the individual was taking just finasteride to when they added the creatine in.
Mm-hmm. Yeah, so creatine is extremely weak and it does not seem to uniquely optimize DHT. It's more of an across-the-board hormone optimizer. So it's not really a upregulator of 5-alpha reductase. Rather, you have more substrate around. You probably have a bit more testosterone, a bit more DHT, possibly even a bit more estradiol as well. So yeah, I would say the effectiveness of both are going to be affected. However, I would not take creatine to prevent finasteride side effects.
Yeah, I think you would get the benefits of both. I don't think that they would cancel out by any means. So the finasteride is not going to block your benefits on exercise recovery from the creatine, for example.
Next, so activating MTOR by exercising will help in spermatogenesis, which will help in neuroplasticity, thus helping in depression. But activating autophagy, or some people call it autophagy, also helps in depression. So how do these things go hand to hand? How can these things both be true?
This is a great question. I presume this is in follow-up to our depression podcast where we talked about ketamine and rapamycin. And this is exactly what the researchers were trying to reconcile because they saw that blocking MTOR, basically you're blocking the outgrowth of those neurons, the neuroplasticity and synaptogenesis mentioned there. In mice, so they said, well, let's see if it blocks the effect in humans, and they found the opposite. So the hypothesis there is that it's probably not enough mTOR blockade to totally shut off synaptogenesis.
Yeah.
Instead, it's blunting the immune response that's perhaps involved in neuroinflammation that is sort of the rate-limiting step on that neuron outgrowth and allowing both of those things to happen. So you get that outgrowth in those new neurons, or the branches from those neurons are able to survive instead of being destroyed by the inflammation or the immune system. So you kind of think of the rapamycin as being a protective factor there, basically allowing the seed to grow.
Mm-hmm. Yeah, that's a good summary. The pharmacology of most mood medications, a lot of them are just not unknown or proposed mechanisms of action. And there's often several confounders that come to play. Another thing that comes to mind is you'd think in a lot of conditions, along with this hypothesis that more neurogenesis and more synapses is better, then why do things like cerebrolysine anecdotally seem to be both very harmful and helpful in some cases? And a lot of that comes down to the individual and what state of mind they're in. That's why we use terms like reshuffling the deck when people ask us, are we pro this or pro that? People have mentioned ketamine. People have mentioned MDMA. People have mentioned psilocybin. There's
things
all
that
these
are going to induce neuroplasticity. It's
Yep.
like, well, how do you feel about where you are right now? If you're it's kind of interesting because I think that the ayahuascas and ketamine and the psychedelics are popular out in these places where people are innovating and presumably very successful, like Silicon Valley. So if you're in that position already and you're doing well, it's a bit of a risk to reshuffle the deck.
It certainly is. So I guess we could say, just like any other medication, there's very good and very bad candidates. So talk to your doctor before considering something like that, because we've seen them be both very helpful and very harmful at the same time. Next question says, great information. Thank you for all that you do. Thank you. If I was prescribed 0.25% topical dutasteride, much more reasonable. Is that still something that should be done 2 to 3 times a week, generally speaking, or is there room to bump it up?
Yeah, basically, I think the one study out there using a dutasteride that showed a hair count improvement in a topical form, it was designed to be an everyday dutasteride, and then the patients admitted, hey, I'm really only using this, I think it was about 4 times per week.
Yep.
So there's probably some benefit there, but for the individual looking at this, they do have to think about net androgens again. We've said that a lot on this AMA, but they have to think about that. And advancing things as tolerated. More is probably going to be more effective in terms of frequency, using it every single day or 6 days a week if you're microneedling or something like that, versus just 2 or 3 times a week. But the level of tolerability from person to person is going to vary. Generally, I would say it's quite good for topical dutasteride.
Yeah, that's a great summary. The other thing to keep in mind in topical dutasteride is I kind of have 2 categories of patients with topical dutasteride. Usually when someone's using topical dutasteride, it's because they want no clinically significant amount to go systemic. So a lot of those people, 0.25, 4 times a week, very reasonable. But I do have that other category where we actually want a tiny bit to go systemic and start to bring down serum DHT just a little bit. Perhaps that slippery slope, foot in the pool, to work them up to once every 10-day oral dutasteride, for example. And in those individuals, I almost always use at least 1%, so a higher concentration.
Yeah, it's interesting. It's just like you'll have some individuals, they take oral finasteride. They say, oh, I got side effects from that, but now I'm using this topical finasteride.
Yep.
And their DHT levels were identical, but for whatever reason, in that topical form, they're not having the side effects, and you can still get benefit. We know that the topical is going to work for prevention and for some people for hair regrowth. And there's a lot of reasons we've speculated about that. Again, check our hair loss podcasts.
Next question. I need to be careful not to develop trust issues from all of this research information, because we talk about the good and the bad of the research. That is true. Every time I see an ad for a clinical trial, I can't help but wonder how much it complicates epigenetics and other things. As a consumer, I feel a little bit like a lab rat. It makes me want to eat mostly whole foods and avoid as many synthetic things as possible.
Yeah, I think that is quite reasonable. And that is really the foundation. I know that you have a famous, we call it a catchphrase, that diet, exercise, or lifestyle is more powerful than any medication.
Yep.
And sometimes someone is having complicated health issues, and you really have to go back and look at the basics, because it's not always going to be solved by a new clinical trial, supplement, or a medication.
Yeah, it's a good summary. If I had not listened to this podcast, I would have not realized that my omega-3 supplement says refrigerate after opening. It's frustrating because all these supplements are not inexpensive. I used to buy cheap ones and I was worried about oxidation, so I purchased Dr. Berg's cod liver oil, which is freeze-dried, but then I thought I would try one that had more EPA, DHA, vitamin D3, and a 2-month supply. I think this podcast is talking about DHA and EPA, but at really high levels. Not sure, or maybe high for certain medical populations. The brand, Body Health, not familiar with it, I'm consuming at the moment, has astaxanthin, which is another reason why I purchased it. I wish you covered freeze-dried to understand that process and how it's compared in clinical trials.
So my take on this is that the freeze-dried is probably not necessary, looking at how well the gel caps tended to do. I honestly don't know if they were looked at like shelf life refrigerated, because when you go into a supplement store, generally the omegas are not going to be refrigerated. Personally, I'll throw mine in the fridge after I pick them up and then take them out whenever I'm using them. But interesting note there with the astaxanthin, there's something about the testing that the astaxanthin can sort of throw off in terms of, was it the oxidation specifically?
Yeah, so astaxanthin seems to throw off a lot of testing assays. And in this podcast that this comment was found under, we did dive into the latest kind of like systemic review of omega-3 testing. And basically there's not a standardized testing for oxidation. So the various oxidized particles that they test for cannot be compared from study to study. So that's the reason why there's not a fantastic systematic review or meta-analysis of these things. But certainly the pure liquids are not as good. And the gummies, I think, were not as good. The gel caps tended to be better if you're not a prepper. So if you don't plan to like stockpile this and take it in 30 years, then the freeze-dried is not really necessary. However, for all foods and all, especially fats, freeze-drying is fantastic. If you've ever seen like LYO, L-Y-O, or lyophilized, it's actually the same thing as freeze-drying. I remember at one point there was a rep for sterile Dutasteride, and they were talking about how their sterile Dutasteride was or was not lyophilized. And I think I said something about, well, why not just freeze-dry it? So that was kind of humorous. But in general, probably not necessary to purchase freeze-dried omegas unless you are prepping.
Yep, I think that's a great summary. Next we have on mesotherapy. Do you think it truly has a localized effect, or do you think it works by going systemic? If it goes systemic, does it prove that even lower doses are still effective? Professor Cecita Corallo used 3 times 1 milliliter of intradermal dutasteride 0.01% injections over the course of 6 months in a 2017 study. Would similar oral dosing make sense? And what would the dosing look like?
Similar oral dosing would not make sense. And I would say with this dose of dutasteride mesotherapy, it is unlikely that any clinically significant effect goes systemic.
Yeah, I think that's the case, because you have to think of it's going to be metabolized quite quickly. And even though the dutasteride studies do show improvement in hair count with mesotherapy, I don't think that by the time you go back, let's say it's a month or 6 weeks between your treatments, I don't think that the dutasteride is still active in the scalp at that point. But it does seem to show that even a short period of time of lowering that DHT seems to have somewhat of a positive effect. Obviously not quite to the same degree as an oral dutasteride would.
Yep. I know a lot of places that are doing dutasteride mesotherapy are using non-prescribed, non-medical grade dutasteride. So that definitely sketches me out. And I'm sure that if it was tested, it probably would not test to have any clinically actionable amount of dutasteride. So if it seems to be working, it's because they're poking holes, causing microtrauma with the needles. That's very likely why. But we also do dutasteride mesotherapy. It's just the supply of it is not very homogeneous at this time. It's better than it used to be several years ago. There are compounding pharmacies making it in the United States now, whereas a year or two ago, there was not. However, as far as I know, all of it is an aqueous solution. So the pharmacology enthusiasts that are watching will know dutasteride is a very lipophilic particle. So it makes a lot of sense not to be in a aqueous solution. It would make more sense to be in an oil. So really, who knows how much you can equilibrate that to the studies. But it is something that if you're already getting some injections, for example, some PRP or even some exosomes or whatnot, it can make sense to add in.
Yeah, I think so. And hopefully there will be an oil-based compound in in a very short timeline soon. Now we have Strange. NP O'Hara stated they had OCD symptoms on Finasteride. I have a long-standing history in diagnosis of OCD. I took Finasteride and it nuked my OCD symptoms to a point where I did not experience any obsessions, compulsions with an associated drop in mood. Is there actually even a study of the use of... There is actually even a study on the use of anti-androgens, including Finasteride, in the treatment of OCD. Someone else commented below that said, I can back this up. I also had a significant decrease in my intrusive thoughts since starting Fin. So Finasteride is actually improving the mental health of people out there.
Yeah.
Improve your mental health by lowering DHT. This is another clip that can be taken out of context.
Yeah, that's interesting. I suppose you could say that some individuals' OCD could be driven by different mechanisms. So one could be androgenic activity in prefrontal cortex or whatnot. One could be parasympathetic tone, sigma-1 receptor agonism, serotonergic.
If you're depleting pregnenolone with the Finasteride, that's a mechanism I think would be plausible, or hypothetically could cause those symptoms. And it just shows how varied the responses are from person to person. We get on Reddit and you can see people are like, oh, my libido is too high on Finasteride. What happened here? Why is this happening to me?
Yeah.
Because it's the opposite of what other people are experiencing. So that makes a great case for individualized medicine.
Yeah, there's a huge variation response to it. Yeah, hopefully these have been helpful. Please leave as many comments, whether it's YouTube or Instagram, or I don't know if you can comment on Apple Podcasts or Spotify, but please comment with all of your experiences or follow-up questions to these questions. And we hope that we've given you some good tools, some good balanced tools to take away.
Yep. Thank you for listening. May God bless you with health and happiness.